All right.
Hey.
So this is Tom and Mike, and we're talking about billing and coding.
Billing.
Billing, no G, just billing.
This is the street version of billing and
Okay,
coding.
so billing and coding. Another billing and coding pearl. Today we're going to talk about critical care. So listen, we talk a lot about critical care, and just as a little bit of background, if you talk to most experts in documentation, they would say probably 20% of your Medicare population when they come to the ER are appropriate for critical care. And for a group like us, I would say somewhere between 9 and 10 to even maybe as high as 11 or 12% of everything that we do is critical care. But as a group, we only bill 4 to 5%.
Right.
So we definitely leave a lot of critical care on the table. So what exactly is critical care, and when do you think about it? Well, there's three components. So the first component of critical care is distress. So the patient has to be in obvious distress. So that can be, and sometimes distress that's not so obvious, and we'll talk about that. So abnormal vital signs, anybody's hypotensive or severely hypertensive or tachycardic. Severe pain. So along with the abnormal vital signs, we're all, now with this whole sepsis thing in SIRS criteria, we're all tuned into, if you've got a high temperature and a high heart rate and a high respiratory rate, you've got SIRS. Well, that's critical care.
Right.
Any potential airway or cardiovascular collapse, so a bad asthmatic, a bad crooper, someone who's had trauma to their neck where you're worried about the potential of airway compromise,
Yep.
a threatened limb, so that could be, an ischemic limb from bad peripheral vascular disease or somebody through a peripheral clot. It could be a penetrating trauma that threatens a limb. Sometimes the obvious distress is not as apparent. For example, a renal failure patient who's got a high potassium, they may actually look pretty good to you, but you get their EKG and they've got peak T waves, and
Right.
if their potassium comes back at 6 or above, that's
Right.
definitely appropriate for critical care.
And these are all things that I think a lot of us have seen over the years, and some of these things I think a lot of us are very comfortable managing.
Sure.
And when we see them, we don't immediately think this is critical care. And so that's probably one of the big points I think to take home from this is that the stuff that you and I think of as critical care might be very different than the stuff a general internist or a general surgeon might think of as critical care.
So there has to be some distress or some threat to life, limb, or body organ system.
Right.
The second thing you need is
High level of medical decision making. So this is a situation where you have to be putting some thought into how you're managing the patient. So what are some examples? Interventions, multiple drips and meds. If you have somebody who is hypertensive and they've got some end organ symptoms and you're giving them some IV labetalol,
Exactly.
that's critical care. If you're interpreting multiple data points, so say it's somebody with chest pain, they've got a great history for it, and you're doing 2 or 3 EKGs because you're worried that the pain is evolving, that would be critical care. You obviously want to document your reevaluations and the response to treatment. That demonstrates that high level of medical decision making.
sometimes you're not even intervening.
Right.
So you can't get a higher level of medical decision making than when a patient comes in with stroke-like symptoms and you're deciding whether or not to give TPA. If you decide not to give thrombolytics, that's still critical care. If you do give thrombolytics, it's definitely critical care.
Right.
But not giving thrombolytics is still critical care in an acute stroke situation because there is no higher level of medical decision making. Say the patient's a little old or they had brain surgery or it's a little out of the window and you're deciding, hey, do I do it, do I not do it? Going down that decision path meets the high level of medical decision making
Right.
test.
Right. Titrating medicines is another one, and so a good example of this is the DKA patient that we have in the emergency department. If you have somebody who's in DKA, not only do they meet it from a threat level, but also the medical decision making is quite high because often those patients are going to be in the emergency department for several hours before they get to bed, and you're going to be through the glucomandir protocol, adjusting their insulin drip
Right.
and watching their electrolytes and watching their fluid balance. And so those high-level management decisions, I think, qualify.
And even if it's an order set and you feel like, oh yeah, well, the patient's just on autopilot, they're really not. You're responsible for every step along the way.
Right.
So any medication used for heart rhythm, so adenosine for SVT, cardizem for rapid AFib, amiodarone for lots of ectopy or other arrhythmias, any IV medication for high or low blood pressure, close monitoring. So we had a case where Someone had trauma to their neck. They were in a non.
I think that was your case, wasn't it?
Actually, it was not my personal case, but
Oh.
it probably would have made me soil my underwear. It was a clothesline injury to the neck, and it was in an outlying facility. I think it was at
I think it was Independence, wasn't it? Yeah.
And so the physician really didn't do very much except arrange for transfer to a trauma center.
Well, recognize the potential for bad things to happen.
Right.
Watch
If you
them very
say-
closely.
Exactly. And so in my mind, there's no question it's critical care. But if you say, well, what did they actually do? I didn't see any drips. They didn't, do any procedures on the patient. You don't have to. That's a patient they're very concerned about. They, made the decision to get the patient to a trauma center. They did close monitoring. They were prepared for an airway, a compromise, but they didn't have to do anything.
Right.
Still critical care. And then finally, you have to document it. So if you can have a high level of medical decision making, you have a sick patient or someone with a problem, but if you don't document critical care, you can't bill for it.
Right.
And the documentation includes what the organ system is at risk. So sometimes it's not obvious. You can just put sepsis, or you can put hypertension, or you can put acute MI, or you can put airway risk. You can put severe electrolyte abnormality.
Right.
There are some things on the note that are already pre-populated, but you don't feel
Don't feel like you have to put in one of those. You can free text in something.
Absolutely. So why are you? The bottom line is, what are you worried about? Then, what did you do about it? So your chart should already say what you do about it.
Right.
Your note doesn't have to put what you did about it, but there are two parts to the note that are critical. Pardon the pun. So
I didn't
you have
catch
to-
that. Oh,
so
gosh.
you have to have
That's
30
bad.
minutes of critical care in order to bill it. So you need a total of 30 minutes in care. And if you understand that even our fastest providers are seeing no more than 2.7 patients an hour, you're almost spending 30 minutes with every patient that you see.
Right.
Many of them you're spending significant less time with. So it's not a stretch to have a critically ill patient that you spend 30 minutes. And that includes time at the bedside, documentation, reviewing records, reviewing results, making telephone calls, making consultations, talking to the family about medical decision making. And so you want to document that time. And then if there were any procedures that were included in critical care, the only procedure that we routinely include in critical care is reading a chest x-ray, because we don't bill
And the EKG.
separately. No.
Oh, I'm sorry.
We
I had it
used to-
backwards.
Yeah, the only ones that we routinely include in critical
Include.
care is reading a chest x-ray, and that should take a minute or two at most.
Yeah.
So you can add that to whatever other time you spent and come up with a total of 30 minutes. And that'll give you your time. And so if you document those three things, you'll have critical care. We're going to talk a little bit more about procedures in critical care in our next segment.
Right.
So we haven't said everything about it.
And we've already talked about a lot of potential critical care patients, but here's obviously a list of some more that we frequently see that I think sometimes people don't recognize as critical care.
Sometimes you can also say a patient with severe pain that's requiring multiple doses of IV narcotics.
So does this mean that every sickle cell patient is a critical care patient?
No, but certainly some sickle cell patients are definitely
I think if they
are.
had sickle cell with a fever and maybe some unstable vital
Acute
signs.
chest syndrome, if they've got
Yeah.
unstable vital signs, a bad renal colic that required, more than 2 or 3 doses of IV narcotics is certainly appropriate for critical care.
Could
That's
be,
a high level
yeah.
medical decision making.
Especially if they have any kind of renal
No
insufficiency as a
question about it.
complication.
But sometimes even pain control can warrant critical care.
Right. So, yeah, as Tom alluded to, next time we are going to go through a case or two, and hopefully that will give you a better idea of what we're looking for and some of the pitfalls that you can experience with critical care.
Absolutely.
So, till next time, guys.